Chronic kidney disease is a common comorbidity in patients with cardiovascular disease, and CKD increases mortality and morbidity. We are here to talk about the impact of CKD on clinical outcomes in contemporary practice that's associated with PCI. And this is from the October 24th JACC Interventions. Specifically, it is a comment on the diagnostic, therapeutic, and clinical trial Conundrum of patients with chronic kidney disease. And it discusses a large pooled analysis of drug-eluting stent registry to look at CKD in the modern era. So to talk about this conundrum the commentary was written by my guest, Dr. Sripal Bangalore, who is an MD and an associate professor at New York University School of Medicine. What I thought was interesting about this whole thing was that while end-stage renal disease is like the end result for some CKD patients, the fact is cardiovascular disease is still the leading problem for these patients.
Absolutely, absolutely. I think this is one of the common misconceptions both among patients and providers. They think that if you have chronic kidney disease, your most common outcome is the kidneys worsening and you're ending up on dialysis. But the truth of the matter is most of these patients will die of cardiovascular causes before they can live long enough to end up on dialysis.
So let's talk about this analysis first of a Korean registry. It looked at nearly 12,500 patients. Almost 1 in 4 had CKD, 23.6%. That's a higher number than I would have guessed.
Yeah, absolutely. So it's very interesting that we are seeing more and more of these patients being sent to the cath lab because they have coronary artery disease. So we're going to see an increasing prevalence of these patients being referred for the cath lab for PCI or diagnostic cath.
Is obesity entering into this? Diabetes, things like that?
Yeah, absolutely. I think this is the result of increasing epidemic of obesity, diabetes, and metabolic syndrome, and so forth. So I think it's only going to get worse, and we're going to see many more of these patients in the next decade or so. And what I address in the editorial is not just the PCI part of it, but also to say, how do we diagnose coronary artery disease in these patients?
Well, you specifically address how patients with CKD break many of the traditional cardiovascular rules. Can you talk about some of those broken rules here with these patients?
Yeah, absolutely. I think that's key to understand if you want to diagnose coronary artery disease in these patients. Because traditionally, we drill this home with our medical students, fellows, everybody. How do we diagnose coronary artery disease? First is you look at the risk factors and come up with some kind of a pretest probability for coronary artery disease. Then we ask about symptoms. Do you have chest pain? Does it worsen when you exert yourself? Does it get better when you take rest? And then we do a stress test. And if that stress test is positive, we say, maybe your risk of coronary artery disease, your probability of coronary artery disease is high. Let's send you for diagnostic cath, and then you see coronary artery lesions, etc. But if you start with patients with CKD, there are plenty of data to suggest that if you just look at risk factors, that won't help you. And if you ask them symptoms, for example, if you say, do you have chest pain? Many of them might say no. And part of this is to do with, these patients have two things going against them. One is very high prevalence of diabetes. And second, they have uremia from their kidney disease. And both of them will cause autonomic dysfunction. This is more like a transplanted heart. They just don't feel the chest pain. So most of them present with shortness of breath. It gets missed.
So chest pain, reduced exercise capacity, risk scores don't work very well. So this is the diagnostic conundrum that you were talking about. What about the therapeutic conundrum?
Right. So therapeutic conundrum is also a major thing because we do a ton of clinical trials in cardiovascular medicine, and we do mega trials. One common factor in all of these cardiovascular trials is we exclude patients with chronic kidney disease. 80% of cardiovascular trials exclude these patients. But in real life, we are faced with this patient. What do we do with this patient? What do we do with statins? What do we do with antiplatelets? But trials have excluded them. We just assume that, that trial results should be applicable to patients with CKD. But the risk-benefit profile is vastly different. And if you just focus on coronary artery disease and what to do with these patients, if you look at Courage, Barry 2D, Freedom, and all of these major trials, most of them excluded patients with chronic kidney disease. So we just don't have any idea what to do with them. What is the best? Should we be revascularizing? Should we just medically treat them? Should we do PCI? Should we do CABG? So we just don't have data. And many of us, I think what we are left with is either expert consensus or individual biases as to what may or may not work.
Right. And then you have the clinical trial conundrum, which is just trying to get these people evaluated and studied.
Absolutely.
So what's the take-home message? Because it's kind of a difficult message here.
Yeah, it's definitely a difficult message. There's no easy answer. I think if you have a patient with kidney disease, we have to look at them in a different perspective because they do not follow most of the traditional cardiovascular rules. Just because they don't have chest pain does not mean that they don't have significant coronary artery disease. So my take-home message is when you're looking at these patients, you have to take the whole situation, not just based on what we think are the traditional rules, but also from a clinical trial perspective, we need more trials which are geared for these patients. Because we're going to see more and more of these patients, we need answers which are more relevant to these group of patients.
And as far as a take-home message, I think one of the ones I'd like to talk about is the fact that it's the October 24th issue of JACC Interventions. Check out the paper itself and then the JACC Interventions editorial comment that we're talking about the diagnostic, therapeutic, and clinical trial conundrum of patients with chronic kidney disease. Please check that out for CardioSource World News and CardioSource World News Interventions. I'm Rick McGuire.